Welcome to this edition of AFMC.
I'll tell you how I got better. I'm
glad to be here.
But a mission to
Delivery of well, I think that we're going to talk about everybody's.
Arkansas is the second highest prescriber.
Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Dr. Andre Paixao. He's a cardiologist with expertise in preventive and interventional cardiology with the Arkansas Heart Hospital. Dr. Paixao, thank you so much for joining us.
Oh, thank you, Robin. Thanks for having me. I'm excited to talk to you about preventive cardiology.
So let's dive right in. Let's talk about educating people on cardiovascular health and what are missed opportunities that you're seeing happening right now.
A lot of people will get counseled on what a healthy lifestyle is whenever they talk to their primary cardiologist or when they seek out this information by themselves online. And honestly, that's the bulk of what you can accomplish as far as minimizing your future risk for things like strokes and heart attacks. But there are certain screening tools that a well-informed patient may choose to undergo. And with that, you can even further improve on your preventive strategies in addition to a healthy diet and lifestyle. Plus, there are a few misconceptions out there on what the signs of cardiovascular problems are and what the ideal strategies to treat things like hypertension, high cholesterol, and things like that would be.
So it's not just about blocked arteries. I mean, it's far more than just that.
That is true. So one of the things that some people come to my office thinking, or at least hoping, is that they can live their lives however they want as long as they catch a blockage in time to prevent the heart attack. And unfortunately, that's not what fits with our current understanding of coronary disease or atherosclerosis, which is the buildup of cholesterol and plaque within the arteries of our body. So it turns out that most heart attacks don't come from a plaque that's creating a fixed blockage, a fixed narrowing on that artery up until the time that plaque ruptures and causes a heart attack. So a lot of our current tools are great at detecting a fixed blockage, 80% narrowing in the artery that limits blood flow to your heart muscle. That will, in most people, cause chest pain or shortness of breath. And in the ideal scenario, will show up on a stress test, which is what most people get as far as a triage or a screening test. The problem is you may not have any one of those lesions that narrow down the vessel, but you can have a lot of non-obstructive plaque. And those are areas in the vessel where you have a lot of plaque buildup and inflammation. One of those non-obstructive plaques can rupture, a blood clot then develops on top of that, and that's basically what a heart attack is. So just by ruling out a fixed blockage, you're not necessarily ruling out the condition that can lead to the worst types of cardiovascular events. It is important to detect the blockage. We can treat that and improve patients' quality of life, but if the goal is to make people live longer, avoid strokes and heart attacks, what you need to detect is the overall amount of plaque someone has, and then institute the strategies to minimize that plaque progression and reduce the inflammation in that plaque. And those are not treatments such as stents or even bypass surgery. Those are mostly treatments such as a healthy diet, exercise, and medications that will act on the whole vasculature, not just on the segment like a stent would.
So is there way too much focus on blood pressure?
That's also something that I guess some people understand differently than what the current consensus is on the medical community. So high blood pressure is certainly a risk factor for heart disease. If left uncontrolled over the course of months or years, a high blood pressure will increase your chances of developing blockages, of developing congestive heart failure, kidney problems, having strokes, and a number of other things. However, high blood pressure is not a sign of a heart problem. It's not a sign of a blockage. So let's say you go to your doctor's office and your blood pressure is elevated. That does not mean you may have a heart problem or a blocked in your artery. It means you're developing a condition that over the course of many years, if left untreated, can increase your chances for strokes and heart attacks. but it's not by itself a sign of a current problem. And then that causes problems both ways, because it can make people concerned that they have a heart condition just because their blood pressure is elevated, when in fact that's not the case. Most people with elevated blood pressure, even if it's very elevated, don't need to go to the emergency room. They can be treated in an outpatient setting, as long as that's not causing anxiety and additional stress. But also, just because your blood pressure is normal, it doesn't mean you're not having a problem. Let's say you're having chest pain, and somebody says you had to check your blood pressure right now, and you check it, it's normal. That can still be a heart attack. It doesn't mean that because your blood pressure is normal in that one setting, that it's not something that needs to be looked at urgently. So blood pressure is an important risk factor for heart disease. It does need to be managed aggressively. However, it's not to be seen as a sign of heart disease, and the absence of high blood pressure should not be reassurance that you don't have a heart problem.
So, is this something that a PCP should be looking for or addressing for a wellness visit? What do you want those physicians to know?
Yeah, in an asymptomatic patient, I think most of the counseling and screening can come from a primary care doctor's office. So if you see somebody who's concerned about their future for the future risk for things like heart attacks and strokes, a lot of those patients will have a family history of heart disease, or they may have a friend who recently had a stroke or a heart attack. You can start off with what's a traditional risk factor assessment. So using someone's age, sex, blood pressure, cholesterol readings, and the presence or absence of diabetes, you can calculate someone's risk for stroke or heart attack using models that have been created in this population-based cohort. So you can go online, put all that information in, and it spits out a 10-year risk for things like strokes and heart attacks. And you can use that information to counsel the patient on adopting a healthier lifestyle, and sometimes starting cholesterol-lowering medications that will minimize the progression of plaque. If you want to further refine that, you can do a calcium score CT, which is by far the screening test with the strongest scientific data behind it. A calcium score CT is a CAT scan without contrast that's going to measure how much calcium you have in the arteries of your heart. The calcium amount is proportional to the plaque amount. It's proportional to the amount of cholesterol and inflammatory cells that you have in the arteries of your heart. And that's by far the most powerful predictor of your future risk for strokes and heart attacks. Once you have that information, you can go back to one of those models online and add that on top of the age, cholesterol, and blood pressure information. And that gives you a much more precise estimate of someone's future risk for things like strokes and heart attacks. It doesn't mean that person will have a blockage. They may not have a blockage, but they may have a lot of non-obstructive plaque and may still benefit from a very aggressive early intervention program, where you're going to have a more aggressive diet, a more intense exercise program. And a lot of these patients probably do benefit from at least low to moderate dose statin, even if their cholesterol readings are not very elevated to begin with.
So, when is it time for a patient to see you?
So any symptomatic patient where the symptoms are likely of a cardiovascular nature should see a cardiologist. So anybody with chest pain, increasing shortness of breath with physical activity, swelling in the lower extremities that's not otherwise explained, and sometimes people with sort of palpitations, feeling of racing heart, passing out, or feeling like they may pass out. I guess those would be the most commonly recognized signs of heart disease. So that patient needs a workup that can sometimes be initiated by internal medicine or family medicine doctor, but that those patients usually end up in the cardiologist's office. And the other one is a patient who is asymptomatic but has risk factors for heart disease. So that can be a smoker or long-term former smoker, somebody with a strong family history, somebody with high blood pressure, especially if that's been uncontrolled over the course of a few years, somebody with diabetes, especially if that diabetes hasn't been well controlled over the years. That person may benefit from a more aggressive screening. And some primary care physicians are going to be comfortable getting a calcium score CT and counseling their patients based on those results. but some of them will prefer just to kind of defer that to the cardiologist. So in my practice, I see both. I see patients who just get everything started when they see me, but I see patients that already come with a lot of that data from their primary care offices, from what their primary care is initially recommended, and some of them have been pretty effectively counseled by their primary care physicians even before seeing me. But if someone's primary concern is their future risk for a stroke or a heart attack, I think the most effective way of further improving upon the risk prediction of a regular model is a calcium score CT. I trust that ahead of other tools like a stress test, which really doesn't have much of a role in an asymptomatic primary prevention patient, as well as some of those other markers like advanced lipids, high sensitivity CRP. Those things have a lower performance in prediction models than a calcium score CT.
And let's change gears for just a minute. Are Apple Watches and personal devices something that the general public should be wearing? Are they screening tools that you recommend?
So, as screening tools for atrial fibrillation, which is a arrhythmia that can lead to strokes, they're not very accurate. They probably will get there. That technology is improving. There are studies that have been published, some of them initiated by academic programs, some of them initiated by Apple itself. They're not very accurate when they detect AFib. So you get a lot of false alarms. Plus, you also have false negatives. You have patients with AFib that did not get an AFib alert. I think we'll get to the point where these wearables become accurate enough that they're used in clinical practice. So for that point, I don't routinely recommend an Apple Watch, but I think they're fantastic tools to motivate and to track your physical activity and improve your fitness level. So by tracking someone's heart rate as well as more advanced metrics like heart rate variability, you can see how hard you're exercising, and it's very common that people overestimate the exercise intensity. So they go out for a walk and they think they're getting aerobic exercise, whereas their heart rate barely got above their resting heart rate. So if you're using that tool to monitor how often and how hard you're exercising, I think you can really improve your fitness level, which should further on improve your cardiovascular health. I don't like it when patients are obsessed over their heart rate and on those alerts. I think that creates anxiety without really adding truly useful clinical information. But using a wearable to track your physical activity, even track your sleep time, your resting heart rate, your heart rate variability, I think that's very useful in a motivated patient.
So, what does Arkansas look like in terms of heart health? Are we in a good place? Do we have work to do?
We're in a good place if you're a cardiologist and want to have a full office. We're not in a good place for public health or from a population-based standpoint. We have some of the worst cardiovascular statistics in the country. We're consistently among the top five worst states in cardiovascular mortality. Some of that has to do with the prevalence of smoking. Some of that has to do with a diet, obesity, diabetes, underserved populations. So there's just a ton of work to be done in a state like Arkansas.
What are screening tools that are most useful that you recommend right now, aside from the CT that you mentioned earlier?
So what you get on a regular checkup is already a lot of information. So just by getting a cholesterol panel, measuring someone's blood pressure, checking a hemoglobin A1C to detect diabetes, measuring someone's weight or waist circumference, that by itself tells you a lot about your metabolic and cardiovascular health, and also gives you some targets, some things that you can start working on. Um, anything on any more advanced testing on top of that, I tend to prefer a calcium score CT on top of other tools that are available out there. But you honestly can can know a lot about somebody with a blood pressure cuff, a scale, and a pretty standard lab draw.
Well, it's so important that this starts all the way with the primary care physician and monitoring your own health and really taking it into your own hands on a day-to-day basis. Everything matters.
You sure does.
Well, Dr. Paixao, thank you for talking to me today, and I appreciate the research and work that you do, that you're changing lives across the state, and hopefully we will no longer be in that bottom 5 and move to the top 5 instead.
Hopefully. Thanks for giving me the opportunity to talk to your audience. Appreciate it.
And that's it for this episode of AFMC TV. Thanks for watching and have a great day.